It's just after 1.
Okay.
So welcome to the very first THETA rounds of 2019. We are very pleased today to have Dr. Mark Eckman giving us a talk on hepatitis C. I have known Mark for many years, 30 years. I see him every year at SMDM, and he was actually my mentor many years ago. Mark taught me to model when I was Tormentor. When I was building a model on PSA screening in like 1989, 1990 at the New England Medical Center. He was like one of the best decision modelers I know, like one of the, so he taught me many things, and he has a lot of demonstrated skills, published very widely. He's the Posey Professor of Medicine, the director of the division, thank you, I said, the Division of General Internal Medicine at the University of Cincinnati, director of some research group, I have forgotten the exact name, published many papers, mostly on cost-effectiveness analysis, has done a lot on shared decision-making, the interaction of shared decision-making and modeling. And we are very pleased to have Mark here today to talk to us about hepatitis C. Mark.
Thank you so much, Murray. A pleasure to be here. Always look for opportunities to come and visit, as I was telling Murray. So what I'm going to talk to you about is some work that we've done and actually are continuing to do, looking at using kidneys that are infected with hepatitis C. So these are deceased donor kidneys. In this particular analysis for patients with end-stage kidney disease awaiting transplantation who themselves are hepatitis C infected. We also actually have extended this work, and we're looking at now using these kidneys in patients who do not have hepatitis C infection, but maybe Murray will invite me back in a year from now. My collaborators, I just want to recognize them. So whenever we do work like this, it's always important to have domain experts. So Steve Woodle and Flavio Paterno are both transplant surgeons. Chiru is a nephrologist, and Ken Sherman is a virologist and hepatologist. So they're all very familiar. Let's see if this works.
Oh. Okay.
There we go. So again, just disclosures. Sorry. Now you can hear me. Okay. So the objectives of my short talk today are to be able to discuss the trade-offs between delaying treatment for chronic hepatitis C while shortening time to kidney transplantation, and that's entailed in the strategy of transplanting HCV-infected kidneys, and to be able to explain why transplanting HCV-infected recipients with HCV-infected kidneys both costs less and leads to an improvement in quality-adjusted life expectancy compared to a strategy of transplanting non-infected kidneys. And this gets into a little bit having to do with waiting times. And then to be able to discuss the impact of using HCV-infected kidneys on organ availability and average waiting list time, again, for recipients who have hepatitis C infection. So I'll keep throwing in some, I like to share not only what I love doing at work, but what I love doing out of work. And again, this is backpacking this past summer in the White Mountains in New Hampshire. So a little bit of background. In 2016, of the more than 500,000 patients on dialysis for end-stage kidney disease, only about 4% of them actually received kidney transplants. So to a large extent, this is due to limited organ availability, and this makes dialysis the kind of the end stage or end destination for most patients with end-stage renal disease. Furthermore, because of all of the blood and needles that are around in dialysis units, there's a fairly high prevalence of hepatitis C infection amongst dialysis patients, listed anywhere between 10 and 15%. So again, a little more background. The scarcity of kidneys for transplantation and the high mortality each year of patients while they're waiting on dialysis has led to consideration of transplanting kidneys from donors who we would not typically have thought of before. And specifically, these are patients with chronic, or donors, deceased donors. That's what we're talking about in terms of transplant, not living-related donors, but those with chronic HCV infection. Furthermore, there are now antiviral medications for hepatitis C that can be used in patients with end-stage renal disease. 3 or 4 years ago, there were no drugs like that. If you had end-stage renal disease, the pharmacodynamics were such that you couldn't use these medications. So it's created, the availability of these medicines have created an interesting dilemma. And that's whether to treat patients with chronic hepatitis C infection prior to transplantation, get rid of their hepatitis C using these new medications, in which case they might experience longer waiting times, because waiting times for non-infected kidneys tend to be longer in a number of observational studies that have been done than waiting times, at least now, from donors who are infected with hepatitis C. And the alternative strategy would be to transplant first before treating for hepatitis, transplant the hepatitis C infected kidney, and then after transplantation, treat the hepatitis C. We did this using a Markov state transition model with 75 states. The model captured a variety of things, including treatment for hepatitis C virus, progression of liver disease. I was telling Rosie that we use her fibrosis progression transition probabilities for that. Fibrosis stage, decompensated cirrhosis, hepatocellular carcinoma, liver transplantation, those are all considered by the model. And then finally, kidney transplantation. We use a lifelong time horizon, so that means the simulation model runs until no one in the hypothetical cohort is left alive. We've used a healthcare system perspective. Outcome metrics included quality adjusted life years, and 2017 US dollars, discounting both effectiveness and cost at 3% per year. Data sources included, in the United States, the US RDS is the largest registry repository of all transplant data. The target population we used was basically the prototypical HCV-infected dialysis patient. So again, using data from the US RDS, the average age for such patients is 57.8 years. And then in the model, we also used the distribution of sex and race, again, based on that population from the US RDS data. And then we also looked at the distribution of hepatitis C viral genotypes, again, based on US national data. The distribution of metavir fibrosis stages, which we heard a lot about during Isa's thesis defense, which she passed, by the way, good job. We don't consider patients with already decompensated cirrhosis, and we also assume that patients are HCV treatment naive, and the point of decision making is just as patients have been waitlisted for a kidney transplant. So the model, again, this is a simplified cartoon of the model, but basically these are the two strategies that we talked about. Before we enter the Markov model, we stratify patients by gender, by race, by viral genotype, as I mentioned before. And now I'll just show you a simplified cartoon of the Markov model. Again, there's 75 states. I obviously can't show them all, but this just gives you a sense of the kinds of things that we're capturing. So for instance, these states here are various fibrosis stages in the pre-treated patients who have hepatitis C already waiting for their kidney. So when the Markov first starts, there's a distribution across these pre-treatment and pre-transplant states. I'm not going to go into this in great detail, but for instance, patients are initially the chance events. We have a Boolean node where we treat for HCV or not, depending on which strategy we're pursuing. Again, patients who are in the strategy treat first and then will transplant when a non-infected kidney comes along would be immediately treated. We model in those who don't get treated whether there's fibrosis progression or not, again, based on Rosie's data. And basically, patients will move along through fibrosis stages if treatment is delayed. I'm just going to show some key data. I'm not going to focus on everything, but whoops. What I want to really focus on here are the average waiting times for a deceased donor kidney. So amongst, at the time we did the analysis, now the data have changed a little bit, and actually in our subsequent modeling, we're using updated data, but they've not changed a whole lot. So for an HCV uninfected kidney, the average is 2.11 years, whereas for receipt of an HCV infected kidney, The average is 0.63 years. You can see the confidence limits are huge because there are lots of things that are both patient-dependent and center-dependent that will impact waiting time. So just calculating the difference, and this is sort of, in any decision model, there's a key dynamic. Here, the key dynamic is the prolonged waiting time. So it's almost 1.5 years longer for an uninfected kidney. But on the flip side is the high mortality rate, and I'll point this out here. Excess mortality rate per year for patients on dialysis, actually for all patients on dialysis, it's anywhere between 10 and 15% per year. What's interesting is that patients who are on transplant lists tend to be a healthier subpopulation, so their risk actually is quite a bit lower, about 7.5% per year. Compared to post-transplant, annual excess mortality is 2% per year. So fundamentally what we're trading off is delaying treatment of hepatitis C but getting a kidney sooner and avoiding time on dialysis at a high annual mortality rate versus having the hepatitis C cured, preventing further progression of liver disease, but waiting longer on dialysis. So that's what the trade-off is here. These are just some treatment-related parameters for some of the direct-acting antiviral drugs. And the point I want to make out without diving into details is that these drugs are very, very effective. In the old interferon-based regimen days, the measure of therapy effectiveness in hepatitis C is something called sustained viral response. So they'll measure whether you're still viremic at some point in time after treatment. And in the old days, 68, 70% was good. With very toxic medications that required 48 weeks of therapy, we now have drugs that basically have sustained viral responses between 95 and 100%, and with anywhere from an 8 to 16-week duration of therapy and much fewer side effects. So this has really revolutionized the treatment of hepatitis C. Just to give you an idea of some costs, these are, the direct-acting antivirals are very expensive. So you can see here, Elbasvir, Rezeprovir is $17,400 roughly per month, and for most patients, it's a 3-month regimen. And then you can see here another one of the regimens, Clopidogrel, Preventasphere, is about $98.30 per month. These are based on we've been using basically VA, Veterans Administration costs in the United States as a proxy for essentially the most equitable acquisition costs for medications. There are lots, as you guys well know, lots of different ways to look for this, but this has kind of become a standard, at least in the modeling that's done in the States. Here is just a little bit, I'm only going to show you again on the cost side. Annual cost for hemodialysis, about $93,000 per year. Transplant costs about $107,000, but then the annual cost thereafter about $38,000 a year, $35,000, excuse me. So you can see there are also big cost consequences. So results. Am I correct to assume that everybody here is comfortable with decision analysis, cost-effective analysis? Or?
Most people. Yeah.
Okay, all right. So again, I've got the results basically discounted at 3% per year and not discounted. Here are the lifetime accumulated costs, effectiveness, incremental cost, incremental effectiveness. So what you can see is that transplanting the HCV-infected kidneys is about $41,000 and change less expensive than transplanting the uninfected kidneys, and also results in a basically is about a half a quality adjusted life year better. So the bottom line is that the strategy of transplanting faster but delaying treatment for hepatitis C dominates the other strategy. And we see the same thing in terms of a similar pattern in the non-discounted results. Let's look at, all right, got my fancy animations, all righty. So we looked at a number of deterministic sensitivity analyses, and basically transplantation with HCV, viremic, or infected kidneys was really robust, superior in almost all of the sensitivity analyses. I'm going to show you a tornado plot of one ways in a moment. But let me zoom in on a few things first, because again, a critical parameter to understand is the difference in waiting time between the infected and uninfected kidneys. So what we see here is a one-way sensitivity analysis where I've actually plotted both the effectiveness, those are the straight black lines, and also the ICER. And what we're looking at on the x-axis is the additional wait time for an HCV uninfected kidney compared to the infected kidney. And you'll remember the base case was about 1.5 years. And what you can see here is that were the additional wait time a lot smaller, below a threshold of a little over an additional year, actually transplant with an HCV uninfected kidney would be more effective. So if there's not a significant difference in waiting time, there's not a benefit to accepting the HCV infected kidney in terms of wait time, at some point, the transplant with the uninfected kidney, becomes better. And then looking at the ICER, you can see that the ICER for transplantation with an HCV uninfected kidney, that's what I'm showing here, basically increases to infinity, obviously at the threshold where the denominator approaches 0. Let me move on. This now, so another feature, I didn't focus on it when I was showing you the key data, but the first month mortality following kidney transplantation with an HCV-infected kidney is a bit higher than the mortality in HCV uninfected kidneys. The base case is about 0.015. For patients, HCV uninfected kidneys, it's something on the order of 0.008, so a much smaller number. So this is looking at a sensitivity analysis of, well, what if this first month mortality following transplant with an HCV infected kidney really were too low? How high does it have to be before it would change from an effectiveness perspective, the decision? And you can see here that there's not a threshold till basically first month mortality after a transplant with an HCV infected kidney exceeds 10%. So very far from the threshold, again, making us more comfortable that this is a robust result. These are a couple of two ways trying to look again at some of the most important parameters that sit on either side of the decision. So this one is looking at on the x-axis, the annual excess mortality after receiving a donor kidney. So you remember the base case, that was 2% per year. And on the y-axis is the annual excess mortality associated with being on hemodialysis. So in the base case, again, at 2% and 7%, you can see that the base case falls well within the region in which transplant with an HCV-infected kidney is best. But again, what it shows here, emanating from the bottom right, if for whatever reason, because of issues relating to immunosuppressive therapy, post-transplantation, and the impact that might have on hepatitis C virus infection. And I should say that there have been studies now looking at that, and this is probably still a very good estimate. But this is just showing you the dynamic of, if you had a situation where post-transplant mortality was a lot higher and mortality was lower for hemodialysis, that would put you in this region, but it's an unlikely region to actually exist. This next two ways, looking at quality of life on the x-axis on hemodialysis, generally it's reported to be pretty poor, around what we used for a base case, again, based on data and literature, was about 0.56, and quality of life following transplant of roughly 0.8. So again, you can see up here, the base case falls well within the region in which using an HCV-infected kidney is best, but you could imagine there might be patient-to-patient variation on values and preferences for health states, and some of the work that we're leading up to is actually trying to develop individualized decision support for making decisions about this. And let me move on. this is, so trying to give you a sense of the trade-off between the development of more progressed liver disease and more progressed renal disease. So what this is actually, we're looking at basically the populations in some of the key health states in the Markov model over the time of the simulation. So everyone starts with some degree of fibrosis based on, again, the data from US RDS. And you can see the majority of patients have mild to moderate fibrosis. A small group have compensated cirrhosis. And we're now looking at the strategy of transplanting with an HCV uninfected kidney. So ultimately, of course, everyone ends up dying. We kept track of how patients died. And the point I want to make here is that in this strategy, using uninfected kidneys, we've got a cumulative probability of death from liver disease of 0.034, and we have a cumulative probability of death from chronic kidney disease of 0.345. Now what I want to do is contrast that to the other strategy. And you're going to kind of have to remember these numbers. But now, so this is the strategy of transplanting with an HCV-infected kidney. Now the cumulative probability of death from liver disease has gone up to about 0.05, but the cumulative probability of dying from kidney disease has dropped down to 0.29. So it's just another way to look sort of within the model and get a better sense of, you know, what's really driving these quality differences in the end. And that was the point of showing this. We also did second-order Monte Carlo simulations with 10,000 iterations of probabilistic sensitivity analyses. And I'm not showing you here a cost-effectiveness acceptability curve. I'm only looking at the effectiveness, the distribution of qualities, and it's actually the gain in qualities for accepting an HCV-infected kidney. And what you can see here is that, number one, in 100% of the simulations, transplantation with the HCV-infected kidney wins. The mean in this distribution is 0.52 qualities with a standard deviation of 0.16. And we also looked, I'm not showing you the cost here, but we also looked at the cost savings, and that was average cost savings of $38,691 with, you know, a modestly large standard deviation of a little over $9,000. Furthermore, if we looked at the cost effectiveness acceptability curve, I'm not showing it to you because it's not all that interesting here because, again, in the base case it dominated. But the bottom line is that transplantation with an HCV-infected kidney dominated, was less costly and more effective in 99.99% of the time and 100% of the time. So there were a few cases where effectiveness was worse and there was an ICER, and it still fell below 50,000 per quality or was dominated 100% of the time. So conclusions, decreased waiting list time afforded by transplantation with an HCV-infected kidney basically increased both quality-adjusted life expectancy and also saved costs across a population. And the availability of interferon-free direct-acting antiviral agents to treat chronic HCV infection in these patients really creates a new opportunity to use organs that we might not have considered before. And again, the main dynamic here is doing so can greatly reduce the waiting time for a kidney and ultimately improve survival by minimizing time on dialysis. And just finally, in an era of increasing success for kidney transplantation and demand that far outstrips the supply of organs, a strategy of deferring antiviral therapy until after transplantation may be both cost-effective or cost-saving and effective. And this is Lakes of the Cloud right before Mount Washington, but let me stop there, and I'm happy to have some discussion with folks, questions, comments, back and forth. But don't give me as hard a time as we did myself.
Yeah. So you kind of touched it at the end, like with transplantation, it's obviously a case of a limited number of organs to go to a certain number of patients. So I suppose if we start expanding that list and then giving these infected transplants to HCV, it kind of frees up the non-infected organs. So do you reckon, did you have any sense of, I don't know if there's any modelling out there, because that's going to have a knock-on health impact for those who don't have hepatitis.
So the question I thought you were going to ask me was, as we start, which is related. Well, but that's a great question. But another, I'll answer both as best I can, which won't be so well. But the other question is that as we start using more HCV-infected organs, what's going to happen to the differences in waiting times? And will, once we are using them to such a large degree, are we going to sort of, dry up the supply such that the difference in waiting times becomes a lot smaller? And so this is the answer to both questions is, it's one, the kind of model that we built is really focusing on the recipients of the organ. So we've not, at least in a Markov model like this, to my knowledge, I haven't figured out how to do it, to model sort of the interplay, the dynamics that might affect some of what are in this model external values coming in. There are modeling approaches that can look at that. So I don't, we have a sense that yes, you're right, that there's going to be some impact on waiting times as a result of these interventions. The other interesting, so as I mentioned to you before, we're doing some work looking at now at using HCV-infected kidneys for non-HCV-infected recipients. And we got some interesting reviews back on an article we're trying to publish, asking kind of a very similar question, which is, well, did your model consider the impact that this new strategy is going to have on HCV-infected recipients waiting for HCV-infected kidneys? And again, well, there's a limited supply. The best that we've been looking at the data that are coming out, and there are some fresh data actually that have come out looking at waiting times for non-HCV infected recipients awaiting kidneys. And what's happened over the last, so that's as recent as about 9 months ago, at least the publication, and then looking at data that are through, I think, 2017. And the trend that we're seeing is that the waiting time for uninfected kidneys hasn't changed a whole lot. The waiting time for HCV-infected kidneys has actually increased, but a little. But we could well anticipate that in the future, if this becomes standard, that the waiting times are going to extend and extend. And again, the point I would make is, well, at least if we have models that explicitly incorporate those parameters, we can look at that. And that, in fact, was the point of that sensitivity analysis, looking at impact on waiting time and showing, yeah, it's conceivable at some point in the future, if we're using so many of these HCV-infected organs, that there aren't any differences in waiting times. The benefit's going to disappear. The other thing that we're very, did you have a question, Murray?
I have many questions, but I'm just going to wait for others.
Well, let me stop there in the interest of time. I can chatter on, but
do you have any differences in wait time in the U.S. depending upon the payer? In other words, private versus public, or is it a social queue that's independent of who's paying for it?
Yeah.
That everybody has equal access to organs.
So it's the latter. The way things work in the States is if you're on dialysis, you automatically have Medicare insurance.
Okay.
So there's basically a uniform payer for all patients who would be eligible for transplant.
Okay.
But there are big differences center to center, which have to do with local organ availability. And the other thing that I would mention, I didn't talk about it a lot here, but adding to the dynamic of HCV-infected kidneys is, I don't know what's happening in Canada, but in the United States, we have a horrendous opioid epidemic, and there are thousands of otherwise healthy young folks dying from drug overdoses, and the most recent data only show that's continuing to increase and increase. A proportion of those patients, because they're using IV drugs, have hepatitis C. So at least in the short term, I don't know about the longer term, hopefully the numbers will go down. In the short term, there's not a diminishing supply of these organs, but it's a very dynamic situation. So, Murray.
Just a comment and some questions. Like Alex is like, if you can, modeling this stuff on cues is, I think, really the next step. So I think that's a hugely important question. Sort of an immunology question. Like, I guess I would feel a bit anxious about putting viral, someone with like an organ that I know is full of viruses into otherwise healthy person. Like, what do we know about, especially in view of the fact that they have to be on immunosuppression more or less indefinitely? So I assume that there is no big effect on outcomes, because just given the way the model is constructed, they seem to do okay, at least in this population. But what do we know about the science of the risk of recurrence in patients who are on immunosuppressive drugs?
So there are the actual clinical trial data. There's not a lot. There are 2 clinical trials that have been published about 2 years ago. Small numbers, about 15 patients in each, so not huge. Basically, looking of uninfected recipients receiving HCV. So that's not what this is, but of uninfected recipients. And obviously, the duration of outcome data is limited because these transplants have only occurred a few years ago. But 100% of them have had sustained viral responses at 12 weeks at the conclusion of therapy. Adverse events, there were concerns about the interactions between immunosuppressive therapy, which you need for kidney transplant, and active virus and treatment of virus. And in the old interferon era, interferon had loads of interactions with immunosuppressive therapy. The side effect profiles have been very benign. Again, small studies so far, and there have been no deaths. But so early data are very optimistic. But again, we need more patients in these studies. And
so I'll just ask one other question.
Yeah.
So if I was to receive a Hep C infected kidney, obviously the psychological effects of bringing something unclean into my body might,
yes,
at least initially, be a little bit difficult to accept. Have you thought about how you would try to study that effect, if it's real or not?
So we actually, I'm waiting to hear on a grant that just went to council on the 11th. And I was forgetting his name. Our colleague in Vancouver is John Gill in that case. But anyways, so we're trying to develop decision support for individual patients, where the notion is that for any given patient, depending on a whole variety of factors, blood type, gender, race, the center in which transplant would occur, waiting times will be different. So we're trying to develop predictive models for that. And then from the decision analytics side of it, to your question, the issues, and part of this study is actually doing empirical utility assessments on patients for hypothetical health states. They're on dialysis now, we'll do that. But then for hypothetical health states of receiving an HCV infected or viremic kidney. And where the subtleties come in are exactly to your point, and we sort of talked about it actually, I said during your thesis defense, but does that mean, for instance, that disutility persists for longer than the physical symptoms? I mean, these patients who are not HCV infected, again, that's not what this model is, but you're giving them HCV virus infection. They didn't have it before. From the perspective of liver disease, presumably, well, at least the study data so far, limited though it is, show everybody's cured. But there's still these psychological aspects in terms of, worry about transmittal to a significant other, the stigma of being infected with hepatitis C, et cetera. So our colleagues up in Vancouver are doing qualitative studies, interviewing patients who've been transplanted with HCV-infected kidneys, trying to get at some of these questions and trying to get at, when we then model it, to be very in the weeds about it. We have 1 month cycles in the model. For how many months or years after transplant with an HCV kidney should we continue to have a decreased quality of life because of these psychological components to things? We don't know the answers to that, but those are some of the things we're trying to look into.
And you're disaggregating the sort of neurocognitive effects from the kind of labeling stigma stuff.
Presumably, again, with patients who are having their ACV infection cured almost immediately, presumably, there aren't the neurocognitive effects that someone with later stage. There certainly are drug side effects, and we're modeling that exclusively. But again, this is great for us too, because I love to get feedback if you've got other thoughts about it.
Well, I mean, I just locally, like, at least in our discussions, we've thought about, because it makes a big difference in terms of how many qualities you gain from treating in the short term, whether people actually have a short-term improvement in quality of life. And you saw that in Aisha's thesis. Like, we have looked at the mostly non-utility data, and there is longitudinal data suggesting that non-preference-based measures of health-related quality of life actually improve after treatment. And the reason for that isn't exactly clear, but the thought is that this is not stigma. This is people feel better. There's evidence that they go back to work, that the brain clears, that there are these neurocognitive improvements that then could be probably translated into some sort of utility increment. That's not quite what I was asking, though. It was like the concept of being unclean somehow. You've got something in your body that is not the way it should be, and that's really more of a stigma labeling effect than the sort of neurocognitive.
So the only way I can figure to capture that, it's real, and we're concerned about that, is in some way by adjusting the utility weight for that health state. But guys must have other comments.
In the US for kidney transplants, just something that we spoke about recently with the liver transplant is this whole idea that a lot of the people that get transplants isn't down to need, but down to kind of these other criteria, such as such as being off drugs or more so with liver transplants being sober. And I was wondering if you had any idea of the interplay of kind of the idea of giving people kidney transplants for the aspect of need, because obviously they have really large quality gains, and how that plays with actually this person's been on the waiting list longer, so they get a preference, and whether that would impact the waiting times.
Yeah, so I am not an expert on organ allocation. There are very complex algorithms that UNOS, which is the United Organ Donation Center in the United States, that kind of decides how this works, has in place. I know from liver, it's based on, as I've mentioned before, MELD score, which is kind of looking at the severity of, biochemical abnormalities, and they tend to give, actually there's a lot of controversy about this, they tend to give livers to the sicker people, and then those who have actually a better chance of surviving longer get delayed. And in kidney transplantation, I'm not sure how those algorithms work. I know empirically there are a lot of patient-specific predictors that impact waiting time, but in terms of what the algorithms are, well, I'm not even going to speculate because I'd just be making stuff up here. I'm not sure. Any other suggestions for us? This is an active area of work we're doing, and again, there's a lot of great minds in this room.
My major suggestion would be to try to figure out how this interacts with the queue, because at a policy level, at a national level, that is hugely important. Like, for example, if you get people off the list, there's such a big bang getting people sort of transplanted, that if you can get people off the waiting list faster, and you're not going to get that with sort of cohort simulation models. You need kind of system models to sort of capture those sort of queuing effects.
Yeah.
And so the next step, I think, would be to move from the cohort model to a kind of a system model and see what the effects of these new strategies would be on the population level quality gains associated with differential transplant policies.
Anyone, you guys do that kind of modeling?
William knows how to do this stuff.
James Thorpe in US actually, James, he has a XCA liver allocations model in the US.
Well, we love collaborating.
Okay, well, call William. He knows how to do it.
Sure. When you have a hammer, everything looks like an apple. Anything else? Well, it's great meeting you all and talking with you today. Thanks for the opportunity.
Oh, thank you so much for coming. Oh, we actually have a little bit of, we have a present for you. So you've gone above and beyond the call of